Assalamu alaikum. First of all, I'd like to express my deep gratitude for the team of OncoEgypt, headed by Dr. Maha Ibrahim and Dr. Reem Ahmed, and all the team of the Ministry of Health, who are very well organizing this eminent event. I'm really pleased to see all this attendance. Now I'm honored to present one of the pioneers in the field of uro-oncology and in oncology in general, a dear friend and one of the best speakers in the field, Professor Dr. Ahmad Hamada, Professor of Clinical Oncology, ex-chair of Clinical Oncology Department, Qasr Al-Aini School of Oncology. He will be talking about advanced metastatic bladder cancer. How can we proceed?
Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. And first, I would like to thank the organizing team and my dear colleague, Dr. Reem Ahmed, for giving me the opportunity to be present in OncoEgypt, second OncoEgypt. And also, thank you, my dear chairperson, Dr. Yusri Rostom, for this nice introduction. My task will be on the advanced metastatic bladder cancer. How can we proceed? This is my disclosure. And as you all know, the bladder cancer is the sixth most common cancer in US, with the third most common in men and the 11th most common in women. 90% of the cases are more than 55 years old, and 73 years is the median age at diagnosis. However, in Egypt, the bladder cancer for both sexes rank at the fourth as new cases and at the fifth as the most common cause of death, and with a prevalence of approximately 24 per 100 million population. Bladder cancer definitely have a very dismal survival rate for those with metastatic bladder cancer. So stage 4, only 5.5% have a 5-year survival. And as you all know, that it is considered as chemotherapy sensitive, especially with platinum-based chemotherapy in the first line. However, the second line single agent chemotherapy or best supportive care is the standard of care for second line. What we did know that definitely high-grade urothelial cancer nowadays have a high mutational tumor burden. And this definitely makes the approval of some of the 5 PD-L1 or PD-1 agents that have been approved, especially in the second line, because of the overall survival benefit over single-agent chemotherapy. However, the issue is that immunotherapy remains one of the most important advances in more than 30 years, but still we have a minority to respond. These are the previous era of treatment options for metastatic urothelial carcinoma, where we have the eligibility for cisplatin-based therapy or the ineligible for cisplatin-based therapy. You can treat it with platinum, either cisplatin or carboplatin for 4 to 6 cycles as a first line. But second line, also we have some of the taxane and the vinflunine. But look to what we have at the year 2020 and 2021. We definitely have for the first line still the platinum-based chemotherapy for 4 to 6 cycles as first line, while for the maintenance treatment or the second line we have the PD-1, PD-L1 blockade, and nowadays we have only the third line treatment, which is the enfortumab vedotin and the erdafitinib. So first, we started by the Javelin Bladder 100 randomized phase 3 trials, which recruit a very good number of patients, 700 patients, with unresectable or metastatic urothelial carcinoma with complete response, partial response, or even stable disease after 4 to 6 cycles of chemotherapy, cisplatin or carboplatin, gemcitabine as a standard first-line treatment. And after a treatment-free interval between 5 to 10 weeks, you can stratify your patient to go for avelumab, which is a PD-L1 IO, 10 milligram per kg every 2 weeks plus best supportive care versus best supportive care. And if you look for the intent to treat population, you have a very good hazard ratio of 0.69 and approximately 8 months survival gain when you add avelumab to the best supportive care. And when we stratified the patient population into the PD-L1 positive population, the hazard ratio moved from 0.69 to 0.56 with a highly statistically significant value. So it seems that maintenance treatment with avelumab is a very good option for those patients to have a response to platinum-based chemotherapy, and especially if you have a PD-L1 positive population. So they approved the avelumab or the Bavencio at June 30, 2020 as a treatment maintenance for patients with locally advanced or metastatic urothelial carcinoma who had not progressed after first-line platinum-based chemotherapy. Then, because of this, why not to go for adding the IO to the chemotherapy? Whether you have the PD-1, PD-L1 chemotherapy plus the PD-1, PD-L1 or chemotherapy alone. And from here, we have approximately three studies. The first one is the phase 3 IMvigor 130, where they add the atezolizumab to platinum gemcitabine versus atezo versus the chemotherapy alone. And the second one is adding pembro to gem-cis versus pembro versus gem-cis alone. And look what we have. When we add the IO to the chemotherapy, we have a minor improvement in PFS in the intent to treat analysis with a hazard ratio of 0.82 and 0.78. But what is more important is that we didn't attain any significant improvement in overall survival in the intent to treat population when we add the IO to the chemotherapy. So addition till now of IO with chemotherapy did not have any impact on the PFS or overall survival. So if there is any role for IO as upfront treatment without any chemotherapy, again, we have the Danube, Durva versus chemo, Keynote-36 as a pembro versus chemo, and the IMvigor 130 atezo versus placebo. And look to the hazard ratio for the all intent to treat population. It is not statistically significant to use any IO in the upfront treatment. So could biomarker selection improve our IO treatment? For example, the PD-L1, definitely you have a statement that say that PD-L1 is clear as mud, because definitely we have different scoring impact for the 5 IOs, where we have some in the tumor cell and some in the immune cell, some in both, some in one of these. So when we took an example for both patients with PD-L1 positivity, we have definitely negative trial in the Danube and in the Keynote-361. But look to the IMvigor 130, we have a hazard ratio of 0.68. But when we look to the PD-L1 percentage in these trials, we have the PD-L1 in the Danube 60%, although that it is negative. The Keynote-361 PD-L1 positive 51%, although that it is negative again. And in the IMvigor 130, PD-L1 is 24%, and this is the only trial that proves that we can use the IO instead of chemotherapy, especially in the PD-L1 positive population. So what about the current label of cisplatinum ineligible PD-L1 high? Definitely you can go for monotherapy versus chemotherapy again if you have a PD-L1 of immune concentration or immune cell concentration 2 or 3, but not 0 and 1. And this also has been shown in the Keynote-361 that whether you use platinum-based in the intent or those with combined positive score of more than 10, still we didn't have any improvement when we go for pembro alone versus gem-carbo. So definitely we have a lot of controversy whether to use IO in the front line or not. Definitely what I would say that you could only take the IO as front line if you have a patient that you cannot give cisplatinum, and number 2, you have a PD-L1 positive score. So what we have to add to the PD-L1? Definitely the ASCO GU 2022 have the tumor mutation burden. If you look to the PFS, definitely if you have more than 10 tumor mutation burden versus less than 10, you have a much better PFS, you have a much better overall survival, and even for the neoadjuvant treatment. So my first take-home message is that definitely for local advanced metastatic first line, still for cisplatinum eligible, gem-cis or dose-dense MVAC is one of the indicated. Cisplatinum ineligible, gem-carbo or pembro, especially if you have PD-L1 positive. Concerning the maintenance avelumab, yes, it could be a very good option, especially if your patient had benefited from platinum-based chemotherapy and of good performance status. So second-line treatment, definitely we have a poor outcome with second-line treatment in metastatic bladder cancer with overall response 10% and median overall survival of about 7 to 9 months. And we have the randomized phase 3 Keynote 045 with the result of more than 2 years of follow-up, which showed an improvement in overall survival to use pembro versus chemotherapy, 10.1 versus 7.3 with a hazard ratio of 0.70 and statistical significant value, but definitely the median PFS was not in favor of pembro versus chemo. So can the new molecular classification guide our treatment algorithm? Definitely we can, but still we cannot apply this because we have luminal cluster 1, luminal cluster 2, the basal cluster 3, and the basal cluster 4. What is very important that the luminal cluster 1 is 30 to 35%. We have the papillary histology, and we have what is very common, the fibroblast growth factor receptor 3 alteration. And based on this, the response to PD-1 or PD-L1 inhibitor can vary by the subtype of urothelial carcinoma with lower response rate observed in the luminal 1. So treatment with anti-FGFR may be particularly appropriate in patients with luminal 1 subtype urothelial carcinoma for whom the immunotherapeutic approach may be less effective. And these are the frequency of FGFR alteration, which constitute approximately 32%, which definitely lead to the discovery of the erdafitinib, which is a kinase inhibitor that binds and inhibits the enzymatic activity of any of the receptor of the fibroblast growth factor 1, 2, 3, and 4. And this is the phase 2 study of BLC 2001, where they randomized the patient with metastatic or surgically unresectable locally advanced urothelial cancer after screening for FGFR fusion mutation on tissue by central lab to erdafitinib 8 milligram per day with potential up titration to 9 milligram, primary endpoint overall response rate. Definitely showed as a phase 2 very good response rate of approximately 40%, and this has been seen more in those with FGFR alteration. What we have as side effects, definitely the central sinus retinopathy observed in 27%, and this will lead to dose reduction in approximately 13%, dose interruption in 8%, and treatment discontinuation in 3%. So they conclude from this phase 2 trials that we have nowadays a drug which can attack the FGFR alteration, which is known as erdafitinib, with a median overall survival of approximately 1 year. However, we should wait the phase 3 study. What we have with erdafitinib as treatment emergent adverse events is hyperphosphatemia, stomatitis, paronychia, and skin and central sinus retinopathy abnormalities. So the second take-home message is that if you have a patient that failed post-platinum, you can go for FGFR alteration. If it is negative, go for IO. If it is positive, you can go for erdafitinib. Lastly, we have antibody-drug conjugate bladder cancer. We have 2 drugs, the enfortumab and the sacituzumab. These are the phase 1 or the phase 2 study with 27% overall response rate for the first one, and this led to the phase 3 trials development. And also the enfortumab vedotin have an overall response rate of 44%, and this led to the phase 3 study, where it is positive study, the AV301, for the overall survival, for the PFS, and even for the overall response rate, 41% versus 18%. These are the side effects, and these are the guidelines that showed that pembro could be of category 1. Erdafitinib also could be used, but definitely one of the preferred regimens post-cisplatinum after failure of IO, you can have the enfortumab or the erdafitinib. So my final take-home message is that in the context of Javelin 100, still avelumab maintenance reinforces the platinum-based chemotherapy as the preferred first-line option. However, we didn't attain any overall survival benefit to either combining the anti-PD-1 IO with chemotherapy or the anti-PD-1 plus CTLA-4 versus chemotherapy alone. Checkpoint inhibitor should be reserved for subsequent therapy, either as a maintenance after platinum-based chemotherapy or as salvage therapy as second line or beyond treatment. And lastly, we have arrived on the precision medicine for bladder cancer, where we have the FGFR pathway and the erdafitinib or the Balversa, which become nowadays one of the lines for FGFR positive alteration. However, definitely we should wait the phase 3 studies. And lastly, the enfortumab vedotin, which is the BATSEP that significantly improved the overall survival, PFS, and overall response rate versus chemotherapy for patients previously treated with platinum-based. And thank you very much for your kind attention.
Thank you, my Professor Dr. Ahmed Hamada, for this exclusive and very interesting comprehensive talk. معلش اعذرونا بقى يعني من الصبح. Any question from the floor to my professor? Thank you, Dr. Ahmed.
Thank you.
Now it is a pleasure to me to introduce my friend Dr. Mahmoud Khalil, consultant of surgical oncology, Damanhur Oncology Center, and his talk is about the use of ICG in laparoscopic nephrectomy.
Thank you, Mr. Chairman. First, I'd like to thank the organizing committee for this kind invitation, and I really appreciate it. My talk will be about laparoscopic nephrectomy with endocyanin green fluorescence navigation. History of laparoscopic nephrectomy started at 1990 by Clayman, the first laparoscopic nephrectomy. The operative time was about 7 hours, and the hospital stay was about 6 days with 1 unit blood transfusion. The use of laparoscopy in the treatment of renal malignancies has been generated a great debate of controversy based on the fear of inadequate cancer control. There is raised concern regarding the risk of port-side seeding and inadequate surgical margin. So, several steps must be taken to prevent port-side seeding, such as handling of the tissue must be minimized to prevent violation of the tumor. Also, attempts should be made to perform a wide and block dissection to obtain an adequate surgical margin. All potentially cancerous tissue should be removed in an impermeable sac and the field wrapped before extraction. This procedure entails removal of gyrotous fascia and its content, including kidney and perirenal fat. Regarding the adrenal gland, if it is invaded, it should be excised also. However, if it is spared, unless there is no direct invasion. What about the indications and contraindication? Laparoscopic radical nephrectomy has been applied to patients with renal cell carcinoma, but it is contraindicated to laparoscopic radical nephrectomy in tumors with renal vein or vena cava thrombi. Also, if the patient has a prior or past history of ipsilateral renal surgery or perinephric inflammation or extensive intra-abdominal surgery, the surgery by laparoscopy will be so difficult. So it may be a relative contraindication. All of us know the preoperative evaluations, but I will concern the contralateral renal function should be assessed well before the operation by serum creatinine levels and also radiologically by contrast enhanced CT, and may be in need for radioisotope renal scan to assess the contralateral function of the kidney. We may need a bone scan if there is increase in the serum calcium or also asymptomatic bone pain. If there is a suspicion for renal vein thrombosis, CT angiography is requested also. What about the surgical approaches? It is transperitoneal approach, retroperitoneal, or hand assisted. The next part of our talk, why endocyanin green? Endocyanin green is one of the fluorescence dye first use of fluorescence in medicine by Roger Murray in 1947. ICG dye was developed for near-infrared photography by Kodak Research Laboratory in 1955 and approved by FDA in clinical aspect at 1959. Intravenous ICG is rapidly bound to plasma proteins, so this phenomenon helped us to found this fluorescence in the lymph, and it can reach the nearest draining lymph node within 15 minutes. After, in 1-2 hours, it binds to the regional lymph nodes. There are no known metabolites up till now, rapidly extracted and excreted by the liver and appearing unconjugated in the liver, in the bile, in about 8 minutes. The usual dose for standard clinical use is 0.1 to 0.5 milligram per milli per kg. What is the principle for using indocyanine green? ICG becomes a fluorescence once excited either using laser beam or by near-infrared light. The fluorescence released by ICG can be detected using specially designed scopes and the camera, and it can be visualized by highly professional image enhancement using special techniques such as image one spice TM Carl's tools. There are a lot of systems, but this one is available at our center. This is the visualization system and its component. This is the light source and the camera head and the lens of special types to help us to find this ICG fluorescence. What about the applications in renal malignancy surgery? ICG can be used either in nephron-sparing surgery or lymphadenectomy. Why? Because it can clarify the vascular anatomy as well as to identify ischemic parenchyma in nephron-sparing surgery. Also, it can help us to study the lymphatic mapping during lymphadenectomy. So it may be a tool for sentinel lymph node trial as the same concept in melanoma and breast cancer. ICG in partial nephrectomy, the dose is 5 milligram per milli intravenous. It can be observed as green light areas on the image in the course of the main renal artery and vein approximately within 75 seconds. An exact discrimination border between perfused and non-perfused tissue can be detected. The branches of the main renal artery also can be identified and highly selective clamped. So the damage will be minimized due to ischemia. Only renal cell carcinoma looked dark in the fluorescence mode. Also, it helped us when the renal score nephrometry more than 7, which need for complex surgery. This is the renal nephrometry score and its parameters. What about the ICG role in lymphadenectomy? It is still a big debate to do or not to do lymphadenectomy, and what is type of surgery, is it sampling or extensive lymph node dissections, and what is our boundaries and limitations. Still there is debate up till now, but tumor size and TNM classification and symptoms classification can help us to answer these questions. We will discuss the transperitoneal approach using indocyanine green fluorescence navigation. This is the equipment required for any laparoscopic nephrectomy, from the basics to the advanced, up till vessel sealing devices and endo-GIA staplers, vascular load. This is the position, this is the situation, or situation in the OR, patient position, surgeon, cameraman, assistant, monitor, anesthesia, and instrument table. Positioning and the trocar placement for right nephrectomy using 4-port site, camera port and other 2 ports, and 1 port for the liver retraction. And this is for the left nephrectomy. The first step in our operation is the reflection of the colon. The colon is reflected to provide adequate visualization of the anterior surface of the geruta. On the right side, the duodenum is mobilized by Kocher maneuver. On the left side, the spleen is mobilized medially. There is some difference for our start of the operation. The peritoneal incision in the right side should be started at the level of the right triangular and right anterior coronary ligament. On the left side, we should start from below at the level of the iliac vessels. And this is show us where to start and where to dissect. On the left side also, we start, as we said, from the iliac vessels below. This is the second step of our surgery. We start to inject the endocyanine green peritumoral, the same concept as sentinel lymph node in breast and the melanoma. نقدر نسرع الفيديو شوية؟ We can inject at multiple sites. As we can see now, the ICG flow within the cannula. Now we can use our system for ICG fluorescence navigation and visualization by Karl Storr's SPICE TM system. We have more than different view using either green light, blue light, or white and black. As we can see now, the ICG flow within the lymphatic. This is the white and black. The white is the fluorescence ICG, which can help us to identify the renal pedicle, renal artery, renal vein, and also the draining lymph node group. This photo shows us the difference between the normal laparoscopic nephrectomy and fluorescence ICG navigation. This is the step after cocharization of the duodenum and inferior vena cava. It's clear now after cocharization, and this is area with fluorescence is the draining lymph node around the renal pedicle, renal vein, and renal artery, which may help us to dissect our lymph nodes for staging. This photo also shows us the psoas muscle at the bed and all the renal area, including the perirenal fat, are excised. This is a step of clipping for the renal artery. We start by renal artery, then by renal vein. We may use hemoclip or metallic clip and using electric device to make our operation more easy. This is by normal white light, and we may convert to the fluorescence green light to be sure that all the draining group of lymph nodes are dissected and nothing left behind us. This is blue light. This is renal vein clipping after we clipped the renal artery. Now we can dissect on the ureter. فاضل 2 slides. And this is the operative field after complete excision of the right kidney with the draining lymph node, and to be confirmed that all field is clear, nothing left behind us. Finally, I can conclude that laparoscopy has emerged as a powerful, minimally invasive surgical tool to treat renal lesions. Patients benefit from decreased morbidity without sacrificing the therapeutic outcomes. Laparoscopic skill requires intensive training and frequent practice. ICG-enhanced laparoscopic surgery can be applied during nephrectomy procedures, offering additional information on anatomy, perfusions, and lymphatic drainage. Our experience demonstrated the potential benefits and safety of this new technology. Finally, discover new technologies that change the way you look at your patient, and when you see better, you can treat better. Thank you. Any question?
Thanks, Dr. Mahmoud, for a very nice presentation. Next talk, current status of pherocytic prostate cancer by Dr. Ahmed Kandil. Ahmed Kandil. Dr. Ahmed Kandil. مش عارف مش مكتوب عليها. مين؟ دكتور عبد ايه؟
Good afternoon. It's my pleasure to be here to talk about current status of theranostics in prostate cancer on the behalf of my professor, Dr. Ahmed Andil, head of the Department of Aswan Oncology Center. My name is Abdel Hamid Abdou, specialist of nuclear medicine. In nuclear medicine, we use diagnostic and therapeutic radiopharmaceuticals. The diagnostic radiopharmaceuticals, either they are gamma emitters or positron emitters, that are used to image and trace the function of the organs. The gamma emitters are imaged using gamma cameras, and the positron emissions are imaged using PET scanners. The therapeutic radiopharmaceuticals either emit beta emissions or alpha emissions, both of which deposit high energy in selected tissues that they are targeted to and exerting their therapeutic and cytotoxic effect. The localization of these radiopharmaceuticals to the target organ is a function of the biologically active molecule they are linked to. So theranostics is an emerging term in nuclear medicine. It's composed of two words, therapeutics and diagnostics, and it's basically the use of a diagnostic radiopharmaceutical in order to predict the response to a therapeutic radiopharmaceutical. It's some sort of personalized therapy that we are undergoing a diagnostic scan prior to giving a therapeutic agent in order to know whether the patient is a candidate for this procedure or not. And it can also be used for follow-up of the patient to assess response to treatment. So when we were talking about prostate cancer, there is a protein that is overexpressed in prostate cancer cells. It's called the prostate-specific membrane antigen. This is a cell surface enzyme that is continually internalized by these prostate cancer cells, making it a very good target for diagnostic and therapeutic radiopharmaceuticals. For example, if we label this PSMA ligands with the diagnostic isotope gallium-68, we can obtain diagnostic value in imaging prostate cancer. Or if we label it with the highly energetic beta emitter lutetium-177, we can have therapeutic effect upon these prostate cancer cells. So we have various kinds of diagnostic radiopharmaceuticals to image prostate cancer, some of which image the amino acid metabolic pathways, some others image the androgen receptors. But the game-changing radiopharmaceuticals are that are PSMA ligands. for example, the gallium PSMA, gallium-68 PSMA-11, which was approved for the FDA for imaging of prostate cancer. It's used for various indications, including localization of tumor in recurrent prostate cancer, especially in low PSA values from 0.2 and 2 nanogram per milliliter to identify the site of recurrence and to potentially guide salvage therapy. It can also be used for primary staging in high-risk patients who have high likelihood of lymph node and bone metastases before surgical procedures or planning external beam radiation. And it can also be used for our topic today for staging before and during PSMA-directed radiotherapy, mainly in metastatic castration-resistant prostate cancer. So this is how a gallium-68 PSMA-11 PET scan looks like in an individual with no PSMA-active lesions. As we can see, the prostate-specific membrane antigen is not entirely specific to the prostate cancer cells, although it is more expressed in prostate cancer cells more than even the prostate cells that are normal tissue. So we can see that there is gallium localization in the salivary glands, in the liver, in the spleen, kidneys, and the bowel, and the bladder where it's excreted. This is another gallium-68 PSMA scan for a patient with widespread PSMA-avid lesions compared to the same scan of the patient using the radioisotope fluorine-18 FDG. And it's very obvious the superiority of gallium-68 PSMA in imaging of prostate cancer, as it can detect more lesions, and it can also confirm the presence of the PSMA receptors. This is a very important information before proceeding with lutetium-177 PSMA targeted therapy. So when ensuring or after ensuring that the patient has enough PSMA expression, we can proceed with the therapeutic radioisotope lutetium-177, which is basically a beta emitter, emits high energy beta particles. When labeled with PSMA-617, which is basically a PSMA ligand that binds to the PSMA receptors on the prostate cancer cells, they can exert their therapeutic effect. And it was approved recently by the FDA in March 2022 for the treatment of metastatic castration-resistant prostate cancer in combination with the standard of care. The administered activity is around 100 to 200 millicurie. The time interval between cycles is 6 to 8 weeks. The number of cycles, 2 to 6, depending on response, prognosis, and renal risk factors. The response assessment is by PSA and post-therapy scan at every cycle, and the addition of cross-sectional imaging every 2 cycles is recommended. This article was published in 2021. Lutetium-177 PSMA 617 for metastatic castration-resistant prostate cancer. And it was found that this therapeutic radiopharmaceutical prolonged imaging-based progression-free survival and overall survival when added to standard of care in patients with advanced PSMA-positive metastatic castration-resistant prostate cancer. Here, as we can see, how lutetium therapeutic agent combined with the standard of care improved the overall survival compared to the standard of care alone, and how it delayed the time to first symptomatic skeletal event compared to the standard of care alone. So the side effects that was found in this clinical trial was fatigue, dry mouth, nausea, anemia, back pain, arthralgia, decreased appetite, constipation, diarrhea, vomiting, thrombocytopenia, lymphopenia, and leukopenia. This is an example of a patient that showed remarkable response to lutetium therapy. The image on the left, A, this is a diagnostic gallium-68 PSMA-11 PET scan showing multiple PSMA-active lesions. And B, the 3 images in the middle are post-therapy scans after the administration of 3 cycles of lutetium PSMA, 6 gigabecquerel each. And the final one on the right, this is a diagnostic scan conducted after the end of these 3 cycles. And as we can see, when we compare the image A with the image C, there is remarkable regression and even resolution of almost all of the lesions detected on the initial baseline scan. Furthermore, the PSA dropped from around 380 to around 1 nanogram per milliliter. So when talking about theranostics in prostate cancer, it's not just limited to lutetium-177 PSMA targeted therapy, but it also extends to radium-223 dichloride. And the concept or the aim of giving this radium to metastatic castration-resistant prostate cancer is different. Here it's used for palliation of bone pain in patients with metastatic castration-resistant prostate cancer in the absence of visceral metastases. Again, it was approved by the FDA in 2013. The method of administration is 55 kilobecquerel per kg body weight given at 4-week interval for 6 injections. Common side effects are hematotoxicity and GI symptoms like diarrhea, vomiting, and nausea. This was the clinical trial that was published in 2013, alpha emitter radium-223 and survival in metastatic prostate cancer. And it was found that the radium, its role is not just limited to palliation of bone pain, but it also prolonged survival in these patients when compared to the placebo, as we can see. And it also delayed the time to the appearance of the first symptomatic skeletal event. So to sum up, the term theranostics is an emerging term in nuclear medicine. It refers to the combination of a predictive diagnostic radiopharmaceutical with a therapeutic one in order to select patients who are candidate for such procedures and to follow up the response to treatment. The PSMA is a protein that is overexpressed over prostate cancer cells, making it a suitable target for radioisotopes, therapeutic and diagnostic radioisotopes, as the gallium-68 PSMA-11 that was also recently approved for imaging of prostate cancer. And the therapeutic radiopharmaceutical, the beta emitter lutetium-177 PSMA-617, which is also FDA approved for the treatment of metastatic castration-resistant prostate cancer in combination with the standard of care. It prolongs imaging-based progression-free survival and overall survival when added to the standard of care. Furthermore, radium-223 dichloride can be used for a different purpose, which is palliation of bone pain in metastatic castration-resistant prostate cancer patients in the absence of visceral metastases. And it was also found that this therapeutic radiopharmaceutical prolongs survival in such patients. Thank you. Okay. Any questions?
Thank you, Doctor.
Okay, thank you.
Now, the second talk about laparoscopic radical nephrectomy, Dr. Ahmed Abdurrahman, Suhag Cancer Center.
Assalamu alaikum. Many thanks for organizing committee. It's my pleasure to be with you today. Laparoscopic adrenalectomy, Suhaj Cancer Center, 3 years local experience. It is important to understand well surgical anatomy and physiology due to specific site of adrenal gland and specific production of essential hormones. Laparoscopic adrenalectomy has become the gold standard for the surgical treatment of most adrenal problems, with many advantages compared to open surgery. Guidelines say that there are many operations for which laparoscopy is the gold standard for care, including laparoscopic cholecystectomy, appendectomy, bariatric surgery, laparoscopic hiatus hernia repair, laparoscopic colorectal surgery, and of course, our topics today is laparoscopic adrenalectomy. The most common indication is the unilateral benign adrenal lesion called incidentaloma for benign adenomas, followed by pheochromocytomas, Cohen's, and Cushing's disease. To some extent, other pathologies. Advantage of laparoscopic surgery, including many advantages, the most important of it is magnified view of operative field, less blood loss, cost effectiveness, patient satisfaction. In addition to the last point in this slide, possible management of coexisting pathologies. This is subhepatic chronic appendicitis dealt with. And this is a large mucocele of the appendix managed by resection anastomosis in the same session in a case of right adrenal tumor. And this is the pathology reveals that low-grade mucinous neoplasm of the appendix. Some radiological finding for adrenal masses. Contraindications for laparoscopic or relative contraindication for laparoscopic adrenalectomy, including tumors larger than 12 centimeters with local invasion, metastatic adrenal disease, and general relative contraindications of anesthesia. Some difficulties related to laparoscopic adrenalectomy, including its friability, making difficult manipulation intraoperative, excess secretion of hormones causing chemical imbalances, and nearby vital structures as inferior vena cava on the right side, or spleen and pancreatic tail on the left side. Adrenal tumors may be a part of some syndromes, as Men's syndrome. Suhaj Cancer Center, where are we now? In Suhaj Cancer Center, we do most of the surgical varieties that should be done laparoscopically, starting with basic laparoscopy, passing to hiatus hernia repair, colorectal surgery, laparoscopic radical nephrectomy, laparoscopic adrenalectomy, laparoscopic radical hysterectomy, and laparoscopic D2 gastrectomy, VATS, and in progress, thoracolaparoscopic esophagectomy. We reached the previously mentioned goals by a long journey we could summarize in some steps. First, sticking to the terminology of safe laparoscopy, starting with patient selection. We pass a steady learning curve. These photos were taken 5 years ago with our professor, Dr. Ahmed Shukri, optimizing our laparoscopic setup, and we will stick to the rules of laparoscopy as boards of position, rules of pneumoperitoneum, rules of dissection technique, rules of electrosurgery, and rules of extraction techniques. We achieve skilled surgeons in our center for safer surgery. Very interested in building up our teams. Safe laparoscopic anesthesia, anesthetic staff is a very important member in the laparoscopic team. Coordination between the surgeon, cameraman, nursing staff, team of technical support, and workers are very important. Keep our knowledge up to date. And finally, we believe that failure isn't a mistake, but the real mistake is to stop trying. A special consideration as regards hormonal secreting tumors and investigation could be covered in the next presentation by our colleague, Dr. Ahmed Hassan. An operative technique for laparoscopic adrenalectomy, either transperitoneal or retroperitoneal adrenalectomy. No evidence indicating that one approach is superior to the other. Which approach to use depends on personal preferences, with some superiority of retroperitoneal adrenalectomy in cases of bilateral adrenalectomy if you will be dealt with in the same session. Early post-operative in the ICU, we monitor vital signs, pain management, bleeding, shock, intravenous therapy, vasopressors, nausea and vomiting. In the last 3 years, 36 cases of laparoscopic adrenalectomy were operated in Suhaj Cancer Center with exclusion criteria of tumors more than 10 centimeters and tumors with local infiltrations. 20 of them were males, 16 females, average age of 39 years old. 22 of them were on the right side and 14 left-sided. Size of the tumor ranged from 2 by 2 centimeters till 8 by 5 by 10 centimeters with an average of 5 by 6 centimeters, standardizing lateral transperitoneal approaches. Average operative time of 79 minutes. Average blood loss were 18 milliliter. Conversion to open surgery occurred in 4 cases, mostly due to inferior vena cava injuries. No mortality rate. Wound infection occurred in 2 patients of conversion group. Postoperative pathology were 18 benign adenomas, 12 phacocytomas, 5 single metastatectomy, and 1 of neuroblastoma. Patient positioning, lateral position, opposite the target pathology. Patient fixed well to the operative table with strap. Both legs were flexed to avoid neuropathy, padding of all pressure symptoms, using of arm support, and a must should be fully monitoring during the procedure. Our port positions. This is a short video for right-sided pheochromocytoma. After exploring the abdominal cavity, liver traction could be done by any mean, starting dissecting the medial border of the adrenal gland from the IVC, which is the main landmark on the right side, and releasing of the triangle ligament through dividing the subhepatic peritoneum, aiming to excising the whole adrenal area, not only the adrenal gland. This is the superior and lateral attachment. It is nice to use a vessel sealing device in one hand and bipolar grasper in the other hand. Aiming to reach the proper upper border of the adrenal area, which lying deeply beneath the liver. Now attention to the main adrenal vein that should be dealt with safety. Don't exert over traction on the vein during management or clipping. Try to be gentle with the handling of the gland. This is the main adrenal vein. Classically, we put two clips distally and one clips medially. Then division of the main adrenal vein, and this is the corresponding changes occurred in blood pressure on the monitor during handling of the gland until we control the main adrenal vein. Then we start for controlling the adrenal arteries. This is superior adrenal artery. All of them are small arteries in size and could be managed by vessel sealing devices. Exposing the posterior muscle, all the gland and periglandular tissue taken with us. This is the middle adrenal artery. The lower border of the adrenal gland separated from the upper border of the kidney. Here is the site of inferior adrenal artery. Then complete dissection of all suprarenal attachment. Our homemade endo bag for specimen extraction. To slide. Nearly finished. And this post-operative specimen. Final picture. Which is difficult, right or left laparoscopic adrenalectomy? Some say that the right, based on the retrocaval location of the adrenal gland or shorter adrenal vein. Some say that left side is more difficult based on the need for splenic flexure mobilization of the colon and complexity of the splenic vasculature and nearby pancreatic tail with need for dissection of the renal hilum. Video for left adrenalectomy, final picture, targeting the drain, to postoperative pathology, and conclusion of the pathology report revealed pheochromocytomas. To conclude, laparoscopic adrenalectomy is the gold standard for removal of most of the adrenal tumors. To be done safely, you should pass a steady learning curve, building up your team, follow up strictly the rules of laparoscopy, keep your knowledge up to date. If there is no invasion of the nearby organs or vasculature, malignancy is no longer considered an absolute contraindication to the laparoscopic adrenalectomy. Many thanks.
Thank you for this very nice presentation. I've told my friend here that it's very tempting to change career to surgery. So next time I'll do this surgery. Any questions?
I have one question, please. As regarding to the pathology, you see that there are 5 cases of metastatectomy. Are these of pathological surprise, and what about the primary?
If it is a single solitary metastasis, after maybe after breast or from any primary, we could deal as metastatic or up revealed it is a single site of metastasis, we could deal.
Any other questions?
Assalamu alaikum. Just I'd like to thank you for this your nice job. But I have a concern regarding most of large cases is pheochromocytoma. Why you don't start by ligation of the vein first? Because any manipulation for the gland will do rising in the blood pressure. So I think it will be better to start to control the vein, and then you will be safe all over your procedure. Just thank you, sir.
This is a classical speaking. I agree with you totally. We have a very good anesthetic team. Even in some cases, we show no change in the blood pressure on the monitor all over the technique due to very good preoperative preparation.
We have a lot of experience regarding these cases, but a lot of cases not appear just inside unless in the operating theater. The patient will have normal blood pressure all over, he is good control, and when you start the surgery and you start your manipulation, the blood pressure will be fluctuated, and then you will have to start this control because it will always be bloody without controlling of the vein. Thank you, sir.
Many thanks.
Thank you. Any other questions? We are short of time, so thank you, Doc. Now I'm honored to present Dr. Ahmed Muhammad Hassan from Sohag Cancer Center. He will be talking about anesthetic considerations for cases of pheochromocytoma.
Assalamu alaikum wa rahmatullah. Thanks for all chairman person. I start with you to give our experience in Sohag Cancer Center about pheochromocytoma and anesthetic consideration. بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. Pheochromocytoma are catecholamine secreting neuroendocrine tumor arising from chromaffin cells of sympathoadrenal system, usually found in adrenal gland, but extra-adrenal catecholamine secreting tumor may originate from sympathic chain to be named paraganglioma. Pheochromocytoma can be isolated or part of multiple endocrine neoplastic syndrome as means 2A and B associated with medullary carcinoma or hyperplastic or hyperparathyroidism, and can also occur in association with neuroectodermal dysplasia and skin manifestation as in von Willebrand syndrome and von Recklinghausen disease. Pheochromocytoma is a rare tumor, occur in 1 per 5,000 persons. However, it is potential life-threatening condition unless diagnosed and well treated. Before it followed rules of 10, but it is now obsolete about bilaterality, malignancy, and extra-adrenal presentation and familial presentation. Secretion. It is neuroendocrine functioning tumor secreting mainly in about 85% noradrenaline and in about 13% adrenaline and 2% dopamine. And according to the secretory hormone will be the presentation. Presentation. All the following presentation are seen in the Sohaj Cancer Center, mostly classical paroxysmal attack of headache, diaphoresis, and palpitation. It may be presenting by central nervous system manifestation in form of anxiety, psychosis, tremor, nervousness, and sense of death. It may be asymptomatic and accidentally discovered with routine imaging. It may be presenting by catastrophic presentation in form of hypertensive encephalopathy, diabetic coma, and cerebrovascular stroke. Very rare to be presenting by syncopal attack during micturition due to presence of urinary bladder paraganglioma. Diagnosis. Clinical presentation will increase the suspicion for the tumor. Then we will follow to try to localize it radiologically and confirm it by biochemical study. Localization. Abdominal ultrasound and CT used routine. It is ultrasound safe and sensitive for adrenal tumor, can be detect malignant featuring masses, can detect bilaterality, and can detect other parts of Neurohoffman syndrome. CT can be used more precise identification of malignant featuring of the mass, can detect tumor in morbidly obese patient, and can detect any metastases. MRI and scintigraphy will be restricted to cases with positive biochemical study and clinical suspicious but absent with CT and ultrasound to detect remote area of pheochromocytoma. Biochemical tests will be good positive but not good negative. Rising of the serum level or urinary level more than 3-fold will be confirmed the diagnosis, including catecholamine itself or first metabolite metanephrine and normetanephrine or the end product اللي هو VMA. Other tests can be used: hemoglobin to detect hematocrit, serum cortisol to exclude Cushing syndrome, serum calcium to exclude hyperparathyroidism, thyroid function to exclude thyrotoxicosis. This slide detects sensitivity and of urine VMA, which is standard in our center, to detect catecholamine. Differential diagnosis: Cushing syndrome, thyrotoxicosis, hypoglycemic coma, and insulinoma, carcinoid tumor, and menopausal symptoms. Preoperative preparation. Management of pheochromocytoma need clear plan for management, aiming to achieve certain goals, including decreased vasoconstriction and restoration of vascular volume, normalization of hematocrit, symptomatic control of hyperglycemic manifestation, reversal of myocardial ischemia, and reducing the intraoperative hemodynamic fluctuation. Preoperative management need proper assessment clinically about the duration of the complaint, severity of the complaint, laboratory assessment about the how many folds about the serum and urinary level of catecholamine and its end product, cardiovascular assessment to assess cardiac function because we need certain steps to give fluid. Second step in preoperative management is counseling of the patient and his relative about the nature of the tumor. It is a functioning tumor and the progress of the disease. It is occur in spells and paroxysmal attack. Third step, to optimize hemodynamic condition before operation. In form of alpha blocker, we better to use doxazocine because it is long-acting drugs present in two concentration, 1 milligram and 4 milligram. We can reach maximum dose 16 milligram given 4 pills. It is tolerable by the patient and increase his compliance. After 1 week of alpha blocker, we encourage the patient to take more plenty fluid and salty food, and we can admit him to give him IV fluid, provided that cardiac condition is stable and can tolerate. After restoring blood volume, we will give patient beta blocker for 5 days, selective beta blocker atenolol or bisoprolol, ranging dose from 50 milligram to 100 milligram. Endpoint of preparation. We have certain criteria, rising criteria for optimal preoperative control, including blood pressure less than 160/80, orthostatic hypotension with blood pressure not less than 80/60, no more than 1 ventricular premature contraction in each 5 minutes, no new ST changes or on ECG. We add 3 for our policy. Increase urine output 1 milli per kg per hour, correct hematocrit, and tight control of tight glycemic control. Hard times in management of pheochromocytoma, including vein section, intubation, surgical manipulation, and after ligation of adrenal vein. Choosing anesthetic technique depend upon for each center both his policy in management of pheochromocytoma. All anesthetic techniques should avoid drug-induced catecholamine release as morphine and ataracrine. Avoid catecholamine release induced by anesthetic or surgical maneuver. Minimizing hemodynamic response to tumor handling. Treat episodes of hypotension, particularly after tumor devascularization. Choice of surgery, laparoscopic versus open. Standard in our center today is to do pheochromocytoma to be excised laparoscopically after we reach the top of the learning curve to obtain the advantage of laparoscopy in less of postoperative pain, earlier mobilization and recovery, less postoperative pulmonary complication, shorter hospital stay, and overall cost effectiveness. Operative management starts in ICU. The day before, we will admit our patient in ICU and give him heavy sedation in form of alprazolam 1 milligram and give him his antihypertensive drug. 1 hour before operation, we will shift our patient to pre-anesthetic room to start IV sedation in form of dexmedetomidine 1 mic per kg as bolus and continue as 0.5 microgram per kg per hour. Give him magnesium 30 milligram per kg and phentolamine 10 milligram as a bolus over 10 minutes. All this drug to stabilize or to try to stabilize hemodynamics of the patient against the surgery which may occur with intubation or handling of the tumor. We transport our patient sedated to OR, full monitoring of the patient, including pulse oximeter, including capnogram, ECG, temperature probe, very important, ECG, and invasive blood pressure. Choice of anesthetic technique. In our center, we use combined epidural and general anesthesia. Epidural for sympathetic block before intubation, and general anesthesia using IV anesthetic propofol in dose of 3 milligram per kg muscle relaxant, cis-atracorium or rocuronium. Opioid, we will use fentanyl in dose of about 4 mg per kg as a bolus. Maintenance after induction of intubation and stabilized hemodynamics, we will maintain the anesthesia through sevoflurane or isoflurane. We prefer isoflurane to control blood pressure. Putting our patient in the position suitable for laparoscopic surgery and maintaining drug, we use nitroglycerin in dose of 1 mg per kg per minute until handling of the operation. Once our surgeon starts the operation, we maintain hemodynamics by IV drugs, either maintenance of nitroglycerin or use of bolus of phentolamine in form of 1 to 2 milligram bolus and 0.3 milligram of propranolol. We correct the IV fluid for the patient and maintain CVB around 10 centimeter mercury. This photo shown by Dr. Ahmed Abdurrahman before. Emergence. After ligation of adrenal vein, patient may show severe hypotension, so we will start vasopressor. Unless vasopressor is a low dose, less than 0.3 mg per kg per minute, we can try to extubate our patient and shift him to ICU. If patient supported with dose of norepinephrine more than 0.3, we will shift our patient ventilated and sedated by dexmedetomidine. Post-operative management occur in ICU for our anticipated problem, including refractory hypotension, which might require large volume of fluid and vasopressor therapy, and hypoglycemia due to excess insulin release and inadequate glycogenolysis. Lastly, post-adrenalectomy, we show patient mostly hypotension or normotension or hypertension, each of which has its own explanation. Thank you.
Thank you for a very nice presentation. Any question? Next talk by Dr. Shifi Zawawi about the bladder preservation procedures or techniques.
Bismillah ar-Rahman ar-Rahim. I would like to thank the organizing committee. My talk today about bladder preservation approach. Regarding males, it ranks the 6th most common for incidence and the 9th regarding mortality. The incidence is much less in females. 70% presented at early stage, 30% has muscle invasive disease. Radical cystectomy remains the cornerstone of curative treatment for muscle invasive disease. Because of the high risk of distant failure, systemic chemotherapy either in the adjuvant or neoadjuvant setting is often recommended. With the results, radical cystectomy plus chemotherapy, the 5-year pelvic control around 80% and 5-year overall survival range from 40 to 60%. What is the rationale for bladder preservation? We have 66% morbidity and 4% perioperative mortality, 25% readmission to the hospital, and 6% admission to the ICU after radical cystectomy. The strategy for bladder preservation include radical transurethral resection, partial cystectomy, radiation therapy, chemotherapy, and trimodality. We don't have a randomized trial comparing surgery with bladder preservation, head-to-head comparison. We don't have any randomized trial. We have the SPARE trial, which is selective bladder preservation against radical excision, and this trial is closed due to poor accrual. The goal of bladder preservation is to achieve the survival benefit comparable to radical cystectomy and to maintain a good quality and quality of life. Radical transurethral resection is indicated for solitary tumors less than 3 centimeter, T2, no CIS, no prostatic involvement, no hydronephrosis. The incidence of recurrence, if applied alone, is very high. Partial cystectomy applied for solitary, less than 5 centimeter, contraindicated if there is CIS or multifocal or prostatic urethral involvement. It has the advantage of preservation of urinary and sexual function and avoids the need for urinary diversion. Here is the results of radiotherapy as a monotherapy for treating bladder cancer. As we see, the 5-year overall survival regarding all stage range from 25 to 40 or 45%, which is inferior to radical cystectomy. This trial published 10 years ago, adding chemotherapy to TUR and radiation. This is the inclusion criteria, around 360 patients randomized after TUR to radio or radiochemotherapy. The chemotherapy used was fluoro and mitomycin. Some patients received neoadjuvant chemotherapy and some patients received hypofractionation. And here is the results. The locoregional disease after 2 years, the locoregional disease control, disease-free survival significantly improved. And the invasive locoregional disease-free survival also significantly improved. And we have a trend toward overall survival, but not significant. And also, the rate of cystectomy is decreased, but not significant. This is a pooled analysis of 6 RTOG trials. After more than 7 years of follow-up, the complete response rate was 72%, and 42 patients, 78%. The 5-year overall survival, 52%. 42 lesions, it increased up to 61%. The disease-specific survival, 64. 42, it increased up to 74%. What's important in these trials, no patient requires cystectomy for treatment-related toxicity. Another meta-analysis of different trials comparing radio plus TUR or the tri-modality and the best results obtained with the tri-modality regarding local control and overall survival. This slides presented in the ASCO 2022. It is multi-institutional matched comparison between radical prostatectomy to the tri-modality. And the results in metastasis-free survival and the distant-free survival comparable between the tri-modality or radical cystectomy. What chemotherapy we choose? We have different trials using fluoro or mitomycin, paclitaxel, cisplatin, cisplatin 5-FU, or cisplatin as a single agent. And we have 1 or 2 trials evaluating the role of neoadjuvant. هل في فايدة إن ندي neoadjuvant قبل الكونكورنت؟ الريزلتس كانت insignificant. يعني إحنا ندي 2 cycles neoadjuvant MCV بعد كده الكونكورنت أو تدي الكونكورنت ما كانش فيه survival benefit. طيب الريزلت اللي احنا شفنا دي ريزلت كبيره. يعني ايه الكي؟ يعني برضه الريزلت دي احنا ما بنشوفش ال 70% و60% والانسنس بتاعت الكومبليت ريسبونس توصل 78%. ليه؟ البيشنت سيلكشن. احنا عندنا ايديال فور بلادر بريزرفيشن اللي هو التي 2 نو هيدرونيفروزيس نو سي اي اس كومبليت يو ار يونيفوكال ديزيز ويز جود بلادر فانكشن. ليس ايديال تي 3 اي انكومبليت يو ار multifocal or poor bladder capacity. Relative contraindication, T3B, T4A, diffuse CIS, not positive. Absolute contraindication, T4B, hydronephrosis or prostatic stromal invasion. Actually احنا اللي بنشوفه في اخر 2 اللي relative contraindication او الابسوليوت contraindication. وده مش عندنا بس، ده برضه بره. يعني النسبه اللي هو بتشوف الايدل دي مش هتزيد عن 25% من العيانين. Regarding الهيدرونيفروزيس هنلاقي ان الاوفرول سرفايفل هتقل من 54 ل 33. الكومبليت ريسبونس هيقل من 64 ل 38. Regarding التيومر ستيج البيشنت ويز بروستاتيك سترومال انفيجن دول كانوا بيبقوا اكسكلودد من الترايلز، ما بيدخلهمش معاهم في الترايلز. Regarding التي يو ار الكومبليت تي يو ار الريسبونس ريت 79% كومبيرد ل 57 للعامل انكمبليت يو ار. المالتي فوكاليتي والسي اي اس بتقلل الكومبليت ريسبونس والاوفرول سرفايفل. طب نرجع تاني، هل في رول بقى للنيو ادجفنت كيمو؟ مفيش، يعني احنا برضو على كل الترايلز اللي موجوده هي كلها كانت نيجاتيف ترايلز. انما لو الراشونال ان البيشنت هيعمل بارشال سيستكتومي، في رول ان هو ياخد نيو ادجفانت قبل البارشال سيستكتومي. طب في لو هيتعالج بالديفينيتيف راديو ثيرابي او الكونكارنت كيمو راديشن، لو احنا عندنا بقى الجزء اللي بتاع الريلاتيف كونترا انديكيشن او الابسوليوت كونترا انديكيشن، لو البيشنت عنده كوموربيديتي هو انفيت فور سيرجري او ريفيوز السيرجري، هل ممكن ان احنا يعني نجرب مع ان هو نبدا نيو ادجفانت؟ ممكن نبدا، بس هو ما فيش ترايلز اتعملت على الكلام ده. بس لازم نتوقع ان هو في المجموعه اللي هي ريلاتيف كونترا انديكيشن والابسوليوت كونترا انديكيشن، لو خدوا التراي موداليتي هو الاوت كام هتبقى قليله. Regarding الراديشن we have split course او continuous course، يعني بندي الكورس كله ال 64 جراي يعني without interruption، او بيتاخد split course ال 40 to 45 وبعد كده ريست وتعمل سيستوسكوبي، الكومبليت ريسبونس بيكمل كونسوليديشن، او لو في ريزيدوال بيتعمل الراديكال سيستكتومي. البيست بريدكتور فور ريكارنس كان التي يو ار بي والكومبليت ريسبونس افتر الكونكوميتنت كيمو راديشن. يعني زي ما هنشوف في التو الكابل ماير كيرف اللي على الشمال دول، سواء العيان واخد نيو ادجفانت كيمو او ويزاوت نيو ادجفانت كيمو، ان في فرق اللوكال كنترول من 83 قل ب 56، ده مجرد ان في incomplete تي ار، مع مع النيو ادجفانت كيمو من 90% قل ل 72. طب في الريجاردنج التكنيك، هل ناخد الليمف نودز ولا لوكالايزد على البلاد؟ زي ما قلنا ان في الترايلز اللي عرضناها في الاول هي البلادر كانسر 2001، ده كان في جزء اخد كونفنشنال هو البلفس وبعدين بوست، او بياخد لوكالايزد على البلادر. الاوكالت ميتاس في البلفس حوالي 11%. في الترايلز اللي هي البلادر كانسر 2001 البلفيك ريلابس كان اقل من 6%، ودي الراشونال اللي احنا ممكن ما نديش البلفيك ليمف نودز لو هي نيجاتيف. طيب برضه هل الهول بلادر ولا تو لوكالايز زي في كل يعني الراديو ثيرابي التكنيكس ان احنا بندي لوكالايزد على التيومر. البوستنج على التيومر ده هيقلل التوكسيستي كويس، بس في تشالنج يعني مهمه جدا ان احنا it's very difficult to know exactly where the pre-TURB tumor was located despite the using of operative report and bladder mapping. زائد we have targeting the region accurate can be difficult on day-to-day basis as the bladder can have significant interfractional and intrafractional movement due to different bladder filling, rectal volume changes and other variation in organ motions. It's very difficult احنا نعمل بوستنج على التيومر بيد اللي جوه البلادر. The most common approach if we use boosting للتيومر 54 gray whole bladder followed by 10 gray boosting على التيومر بيد. What about hypofractionation? We have two trials, bladder cancer 2001 and Beacon trials. This is a meta-analysis of those two trials comparing ال 64 versus ال 55 grade in 20 fractions. وكان البرايمري اوبجكتيف اللوكوريجينال كنترول والليت توكسيستي. دي الانكلوجن كرايتيريا بتاعت البيشنت، وكان الارم بتاع الهايبوفراكشنيشن كان بياخد برضه كونكوميتنت كيموثيرابي. ما كانش في فرق ريجاردنج اللوكوريجينال كنترول اور الاوفرول سرفايفل او الليت توكسيستي. وبناء عليه كان conclude implication of all the available evidence with these finding 55 gray in 20 fractions over 4 weeks should be considered as a new standard of care for bladder preservation. هي برضو طبعا احنا الكلام هنا برضو ان العدد قليل، يعني كان حوالي ما يعديش ال 200 بيشنت، ان احنا نغير، انما في عندنا بيزس او عندنا ايفيدنس ان انت لو عايز تدي لوكالايزد على البلادر. What about the late toxicity? As we said, ان احنا لو الهدف الجول من البلادر بريزرفيشن الاوفرول سرفايفل تبقى سيميلر للسيستكتومي، والتوكسيستي تبقى اقل من الراديكال سيستكتومي. With this trimodality treatment, the late toxicity are around 6% في الجينيتورينري and 2% في الجاستروintestinal. Regarding the quality of life, the physical function, the social function, emotional function, cognitive, fatigue, and pain, all in favor of trimodality. The urinary and bowel and sexual function better for the trimodality than the radical cystectomy. Can we improve the outcome with trimodality? We have trials incorporating immune checkpoint inhibitor with radiation. ده راشونال اللي هي الباسيفيك ترايل. الباسيفيك ترايل في اللنج بعد الكونكومنتنت كيمو راديشن كان المينتنس بالدورفالوماب ادى الى significant BFS and overall survival benefit. We have phase 1 and phase 2 evaluate السيفتي بتاع انكوربوريشن للاميون تشيك بوينت انهبيتور مع الراديشن وكانت سيف. ده ادى الى we have 2 phase 3 trials الاتيزو بلس الكونكومنتنت كيمو راديشن فيرسس الكونكومنتنت كيمو راديشن. يعني دقيقة بس كمان دقيقة. والترايل الثانية كانت البيمبرو مع الكونكومنتنت كيمو راديشن والبرايمري اند بوينت هي البلادر انتاكت ايفنت فري سرفايفل ودي لسه يعني لسه النتائج بتاعت الترايل دي ما اتنشرتش. طب الكومباينيشن مع الهايبوفراكشنيشن فيز 1 ترايل ادت الى التوكسيستي كانت عاليه جدا فالترايل دي وقفت بس هو ستيل في اون جوينج ترايل بس ويز كوشن. التوكسيستي في الفيز 1 وفيز 2 مع الهايبوفراكشنيشن مع الاميون تشيك بوينت انهبيتور كانت التوكسيستي عاليه. To take home message, trimodality is an excellent treatment option for selected patient. Oncological outcomes will be equivalent with between trimodality and radical cystectomy. It is associated with good functional outcome and long-term pelvic toxicity. We need to improve the outcome exploration of immune checkpoint inhibitor with radiation in multiple trials. Still, we need a biomarker to personalize the treatment. This is the NCCN recommendation for stage 2, category 1, surgery or bladder preservation, وفي stage 3 also surgery or bladder preservation. And thank you.
Thank you, Dr. Sharif, for this very nice presentation. Now it is a pleasure to me to introduce my friend, Professor Dr. Walid Fadlallah, one of the figure of genitourinary surgical oncologist at NCI, and his talk is about partial nephrectomy in the management of renal neoplasm.
انا عايز ماوس. لا عايز ماوس عشان هسرع الفيديوهات هحتاج اسرعها فانا هحتاج ماوس. هي قالت لي في ماوس ده ممكن تشتغل عليه عشان هحتاج اسرع الفيديو عشان الفيديوهات ده هيقدم. ماشي كده بس انا هحتاج. بسم الله الرحمن الرحيم. Thank you, my dear friend and our chairperson. Thank you for attendance. Today I'll start to talk about partial nephrectomy in surgical management of renal neoplasm. Our National Cancer Institute experience. Nephron sparing surgery is currently considered the best alternative in treatment of renal tumors less than 4 centimeters, and now the indication expanding to selected cases of lesion up to 7 or more than this, whether open or laparoscopic or robotic, compared to radical nephrectomy and benefit of preserving renal function. Nephron sparing surgery has gained popularity after several studies that demonstrate higher incidence of chronic renal failure after radical nephrectomy and the direct association between renal insufficiency and cardiovascular morbidity and mortality. طبعا no way to preserve the kidney, it's better than you remove it. Several studies has demonstrated the surgical and oncoplastic safety of nephron sparing surgery in terms of local recurrence, long-term cancer-specific survival, and the overall survival, which is comparable to radical nephrectomy. Partial nephrectomy is technically more challenging. The problem is that partial nephrectomy technically challenging procedure. you have small time, you will need to do more procedure, so it's easy to do radical nephrectomy, but it's more difficult to do partial nephrectomy. renal scoring system الحقيقه فيه كذا scoring system يقدر يقول لحضرتك liability to do partial nephrectomy. The renal scoring system is very nice. ده بيعتمد على الراديوس، حجم القطر التيومر نفسه، او الاكزوفيستي. كل ما كان اكزوفيتيك كل ما كان طبعا اسهل. النيرنس تو رينال ساينس، كل ما قرب للرينال ساينس كل ما صعوبه السيرجري نفسها هتبقى اكتر، ان انت ممكن ما تقدرش تعمل بارشال نفليكتومي. الانتيريور is more easier than posterior. And finally the location in relation to the renal balls، في upper renal ball lower renal ball. الحقيقه كل نقطه من دول بتاخد سكورينج سيستم according to it and we collect and then we show the liability to do partial nephrectomy. Our study today, this retrospective descriptive cohort study, including with renal masses treated with partial nephrectomy in our cancer, in the National Cancer Institute, just open or minimally invasive, laparoscopic or robotic. These cases was treated by surgical intervention can 2015 to 2018. Patient inclusion criteria اللي احنا في الستادي patient not more than 70 years، طبعا no renal vein thrombosis, no lymph node, T1 or T2 lesion and M0. The study was performed at our National Cancer Institute, Cairo University. Tumor size, site, and relation to renal pelvis and vascular pedicle were assessed by contrast-enhanced tomography, abdomen and pelvis, warm ischemia time, estimated blood loss, operative time, and post-operative pain. Post-operative complication and hospital stay were recorded. Different technique we used. الحقيقة احنا يعني كنا open أو minimally invasive. الopen technique يعني as we see we just you need to do partial nephrectomy. You have to do complete mobilization of the kidney and identification of the renal vessels. We use the occlusion of the artery, not total vascular occlusion. Just we clamp the artery. As we see here, we just localize. We just identify the artery to put the clamps or the vascular clamp. This is the specimen with different procedure. And this is a nice case of partial nephrectomy. This is a horseshoe kidney. This is the left kidney, this is the right kidney, and this is great vessels, and the tumor was in this area at the isthmus, like the thyroid. So it's what we did it in open technique. Another procedure we use laparoscopic, but laparoscopic partial nephrectomy need just very you have to do more cases to do a laparoscopic partial nephrectomy. Because when you start the minimally invasive technique, it will easier for you to do radical nephrectomy. So they assume that many cases of renal masses could be a good candidate for partial nephrectomy, but the era of laparoscopic or minimally invasive, they did radical nephrectomy. So we just find a solution. You can start laparoscopy, do complete mobilization, identification, and then you can open small wounds and deliver the kidney, and then do your procedure. This is the small incision, and now after we remove the tumor, we close it using our technique like robotic and laparoscopic. We use sliding suture with hemolock and pledged. Laparoscopic, this is the wound up to 12 centimeters or something like this, very small, and you did it minimally invasive. Finally, robotic. We did about 8 or 9 cases of robotic using the Da Vinci system SI. This is the Da Vinci system. just to, now we will see the clamping of the artery. We identify the artery here. We put two vascular or bulldog clamps on the artery just to ensure that there will be no bleeding during resection or closure of the defect. This is the first one. I'd like to make it more rapid just for your time. ممكن تسرع لو يعني this is the other one and then we this is our start. Now the other one, this is the tumor. This is the resection. Okay, we did complete mobilization of the kidney, and this is a tumor exophytic, very nice. And this, the ventricle. Here we just do sharp cutting to have, as we see, very small safety margins. You don't need 1 centimeter or something like this. You just take a rim of renal tissue as a safety margin. The important point, not to invade or just do any rupture for the capsule. You have to put the capsule intact for the tumor, even if there is no renal tissue on the tumor, but the capsule should be intact. As we see, you can remove the tumor from the kidney, and you can see with magnification of the robotic system how nice the collecting duct, the vessels. Yes. After we finish removal of the tumor, now we will use the sliding suture. This is the vein. And here is the defect. If you notice, with resection, you just tailor how you will close. You make this concavity just to close the defect upon it, to not to let any space. Now, how we see the benefit of suturing using the robot will be very nice. So the robotic partial nephrectomy is standard. Laparoscopic till now, it will need very, as we see, learning, very challenging learning curve. Now when we close the defect, we close it in 2 layers. This is the inner layer. And now we will put the hemolock, and then you do this, what we call the sliding suture. It's very nice, and we use it in open technique. You can use it in open technique. It's very nice. That the problem is it will cut through the tissue. The normal suture will cut through the parenchyma of the renal tissue. And now we put the other one, and then, as we see, the defect is disappeared. You just fold the kidney over each other. And then this is the final. Now, after you finish, you can remove the clamp over the artery, and then to check there is no bleeding, and then close the fascia over, or the gyrus fascia over this defect, and then you finish your procedure. One important point about intraoperative ultrasound. I think you should have intraoperative ultrasound during partial nephrectomy. In many cases, maybe you find some lesion in the kidney, and when you go to surgery, you are in doubt. Is this real neoplasm, maybe inflammatory, I'll do surgery or not. So the intraoperative ultrasound will localize the tumor and show you the extension. The renal mass identified with intraoperative ultrasound. Gyrotous fascia is opened and the perinephric fat overlying the mass is widely excised to provide adequate exposure to the renal capsule. The renal capsule is scored with the cautery to demarcate the line of your resection. Our result mean operative time was 187 minutes. Blood loss less than 413 milliliter. Mean warm ischemia time is 22 minutes. طبعا the optimum not more than 25 minutes. One laparoscopic partial nephrectomy converted to open radical 1, and 2 laparoscopic partial nephrectomy cases were converted to open partial. 3 patients have positive margin. As I said, positive margin in studies, no problem unless the capsule is intact. Many studies, there is no big difference between the survival in negative or positive margin unless the tumor is intact. Conclusion, nephron sparing surgery is acceptable, safe procedure that can done open, laparoscopic, and robotic, which result in short hospital stay and preserved renal function, but moderate blood loss and long operative time, which can be reduced by improving learning curve of operating surgeon. We recommended adoption of nephron sparing surgery in any case with renal neoplasm indicated for partial nephrectomy. Thank you, and thank you for my team in National Cancer Institute, and thank you for our mentor, Dr. Amr Fergani. He was a great help in our program. Thank you.
Thank you for this nice presentation. Now I'm honored to present Dr. Ahmed Safan, Fellowship of Interventional Radiology, University of Bologna, Italy, Head of Radiology Department. He will be talking about the science and art of radiofrequency ablation of renal tumors. Please, Dr.
السلام عليكم. أنا دكتور أحمد سعفان, Consultant of Interventional Radiology, Tanta Cancer Center. Thank you for the organizing committee. My talk today about the role of radiofrequency in treating of renal neoplasm. Renal cell carcinoma is the most common primary renal malignant neoplasm in adults. It constitutes about 90% of the renal tumor. The peak age between 55 and 84 years old. About 20% of renal cell carcinoma are presented with metastatic disease. About 2% are presented with bilateral disease. Increasing incidental detection in the early stage due to widespread use of the advanced medical imaging. Renal cell carcinoma are classified. Renal tumors are subdivided into benign and malignant neoplasm. Benign as angiomyolipoma and oncocytoma. Malignant tumors are subclassified into conventional papillary, chromophobe, collecting duct carcinoma, medullary carcinoma, and unclassifiable. Prognosis of the renal cell carcinoma depends on size, location, type, and renal function. Minimal invasive technique of renal tumors, including radiofrequency ablation, renal cryotherapy, microwave thermotherapy, reversible electroporation, and a high-intensity focus, ultrasound, and intracavitary photon irradiation. Advantage of the minimal invasive technique is that it nephron sparing and low morbidity, fewer complications, outpatient or overnight stay only. Detection of increasing number of small incidental renal cell carcinoma necessitating development of less invasive treatment option to replace nephrectomy, either partial or total. Percutaneous imaging guided ablation methods are promising alternative techniques and particularly suits patients with solitary kidney, advanced age, comorbidities preventing surgery, multiple or bilateral renal cell carcinoma. Specific consideration in the renal cell carcinoma ablation comparing to liver ablation. It is different from RF in the liver because it is very tricky due to anatomical consideration of the tumor location, high risk of the adjacent organ injury, higher heat sink effect due to high vascularity. What to evaluate before? Proof of malignancy, biopsy may be required. Size of the lesion, below 3 cm is the best, between 3 to 5 cm can be done. Localization of the lesion, either central or not. Contact organ, pleura, bowel, or ureters. Tumor selection is very important. There is a non-suitable patient like uncorrected coagulopathy, patient with acute illness, locally invasive tumor with metastasis. And there is more suitable tumors with small lesions less than 3 cm or 3 cm, peripheral or exophatic lesions, posteriorly situated lesions or lesions at the inferior bole. Challenging tumor is large tumor up to 5 cm, central tumors or anterior location. Rule of the pre-ablation biopsy is very important that should be considered because of benign mass may mimic malignancy on imaging. Anatomical consideration, anterior or posterior location, central location, lower success rate with risk of collection system or vascular injury, tumor size below centimeter, single session, 3 to 5 centimeter may need multiple sessions. Anatomical consideration, adjacent organ to be considered, a small and large bowel, ureter, genitofemoral or ilioinguinal nerve, psoas muscle, adrenal gland. This very near organ to be injured in the maneuver. Tricks in the ablation or in the radiofrequency of the renal cell carcinoma. Cold perfusion technique used when the renal tumor is centrally located or in the treated tumor margin was close to the ureter. Hydrodissection technique used if the lesion is close proximity to the lower lobes during treatment, location of the tumor, anterior or midpoint, lack of the intra-abdominal fat. Heat sink effect. More heat sink effect due to high perfusion organ. Repeat ablation cycle may be needed, especially in the high perfused tissue. Delay impedance rises. Lower temperature during or just after radiofrequency ablation. This is a case of one of our cases in Tanta Cancer Center. Is a female patient aged 65 years old with solitary kidney. She has left nephrectomy 5 years ago after presence of the renal mass, proved to be renal cell carcinoma. The right kidney shows inferior mass, about 3 cm. Biopsy was done and proven to be renal cell carcinoma. This case was discussed as our MDT unit and take the decision to do radiofrequency. One session of the radiofrequency was done with satisfactory results and no complication was reported. Follow-up 3 and 6 months later was done by contrast-enhanced CT scan, showed that no activity. Another case, female patient aged 53 years old with morbid obesity and other comorbidities that made her unfit for surgery. The patient shows right kidney mass about 4 cm, proved to be renal cell carcinoma by biopsy. MDT took the decision to do radiofrequency. One session of the radiofrequency was done with satisfactory results and no complication was reported. Follow-up 3 and 6 months later was done by contrast-enhanced CT, shows that no activity. Post-ablation care. Next morning, MRI or contrast-enhanced CT as a baseline for follow-up imaging and to detect if there is a residual tumor or any complication. Imaging surveillance every 3 months for the first year, 6 months for the second year, and yearly afterward to detect recurrence and to detect new tumors and if there is an extrarenal disease. Complication. Low-grade fever is controlled. Delay pain, nausea, vomiting, and malaise is self-limiting and controlled by anti-inflammatory agent. Mild hematuria, self-limiting and increasing with ablation of the centrally located tumors. Pain and paresthesia at the pericutaneous probe insertion site is the most common. Bladder outlet obstruction may result from clot formation. Perinephric hematoma, cauterization while electrode withdrawal can control this perinephric hematoma. Also, thermal injury to the ureter may develop urinoma or urethral obstruction or chronic stricture. and can be avoided by cold 5% dextrose in water retrograde pyelographic. Genitofemoral nerve, psoas major muscle injury. Conclusion. Percutaneous image guiding ablation of the kidney neoplasm is safe and effective. It is minimally invasive treatment option alternative to surgery. Appropriate patient ablation method and guidance modality selection and post-ablation survival are important factors for satisfactory result with fewer complications. Thank you.
ثانك يو دكتور احمد. محاضره جميله صراحه، بس عيبها حاجتين، التايم بتاعها ما فاضلش معانا الشهداء دول. والحاجه الثانيه ان انا بصفتي كراجل جراحه يعني الحاجات الصغيره دي احنا برضه هنعملها لاباروسكوب وهنعمل لها بارشل نفريكتيف، بس عموما يعني ممكن نسيب الحالات اللي هي انفت.
على العموم احنا
اتفضل دكتور وليد.
bilateral renal tumors، هي العيانه كان عندها bilateral، واحد كبير جدا وايمنج فور بارشال نفريكتومي، وواحد صغير بس قريب يعني في الميدل اللي هو في الرينال سكور ده، رغم ان هو صغير بس difficult فور سيرجري. فعملنا ستيج، عملنا بارشال نفريكتومي على الرايت وجينا على الليفت اللي هو الصغير. فالعيانه بنعمل لها كونسلنج ان هي ممكن، طبعا الرايت كدني موجوده بس الفانكشن مش اوبتيمم، فممكن لو عملنا نفريكتومي راديكال على الليفت سايد تعمل رينال دياليسيس. العيانه قالت لي لا انا مش عايزه رينال دياليسيس، في الترناتيف. قلت لها والله ممكن نعمل راديو ابليشن. العيانه فعلا عملت ابليشن وفولو اب فور اباوت يعني 3 years وستيل السايز بتاعها ما كبرش. فهي زي ما بقول لك في حالات زي دي لا it will be a big.
هو الدكتور وليد قالوا فعلا دي الابسوليوت انديكيشن بتاع الراديو فريكونسي
برضه على اساس هو انت زي ما الدكتور يعني هو دكتور رجب بيتكلم على ليجن في كدني واحده وصغير وعيان فت، مش لكن بقى في سيتويشنز عيان اولد ايج ماشي على انتي كواجيليشن ريسكي بايلاترال، فدي لا بتفرق معاهم قوي يعني لو هم.
شكرا.
شكرا دكتور احمد. شكرا لحضراتكم جميعا، وبكده نوصل لختام السيشن بتاعنا وختام اليوم الاول للمؤتمر. شكرا لحضراتكم وكل عام وانتم بخير. اتفضلوا.